Well, good afternoon, everyone. And again, thank you for joining us on our latest installment of EMS Focus, a collaborative federal webinar series. My name is Noah Smith, and I'm a project manager with the Office of EMS here at NHTSA, the National Highway Traffic Safety Administration. And together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS as a key player in health improvement. The projects we undertake and the resulting resources for the community help to plan for system improvements, measure the health of EMS systems nationwide, and deliver the data that EMS leaders need to advance their individual systems. And another role of the Office of EMS is to educate the EMS community on new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. And so this free webinar series, again hosted by our office at NHTSA, is a unique opportunity for federal EMS agencies to share information with the EMS community in a manner that's more personal and less time-consuming than attending conferences, but offers the community the opportunity to interact and ask questions in a way that a newsletter or an article really just doesn't allow. EMS Focus conducts webinars on issues that are important to the EMS community and provides you with timely information on what federal agencies are doing about them. So just a note to our viewers and listeners today, today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. To find more information on the EMS Focus webinar series and to watch recordings of the previous webinars, head to www.ems.gov and click on News and Events. So in 2014, there were more reported opioid overdose deaths than ever before. We are in the midst of a growing epidemic that is affecting communities across the nation every single day. EMS is often the first to arrive on the scene of an overdose, which gives practitioners an important responsibility in providing timely and appropriate care. There is also an opportunity for EMS to provide valuable information to public health and other partners and play a role in preventing overdoses before they occur. Agencies, states, national associations, and federal organizations are really coming together to think of new ways to address this crisis, collect and share data, and put policies in place to prevent overdose deaths and save lives. Today we'll discuss how leaders and groups at all levels are collaborating and innovating to reduce the number of opioid overdose deaths and prevent potential overdoses in their communities. We'll discuss efforts happening at the federal level to combat this public health emergency. We'll hear about innovative programs that New Hampshire is piloting to track overdoses and provide a safe place for substance abuse referrals. We'll also learn why New Orleans EMS partnered with public health to track and monitor opioid overdose incidences and educate the public on naloxone, and how the New Orleans Health Department brought together EMS, public health providers, and hospitals to collaborate on efforts to prevent overdoses. As always, during these EMS focused presentations, attendees are encouraged to submit questions using the questions box on the webinar platform at any point in the discussion, and we'll address those questions during a Q&A session at the end of the presentation. Now, it's really my pleasure to introduce our incredible panel that you're going to hear from today. With us today are really EMS and public health leaders who are finding new ways to track the opioid overdose epidemic and bring providers in the community together to offer the most appropriate services. Jeremy Kinsman is a public health fellow with the Office of EMS here at NHTSA, where he focuses on increasing knowledge and awareness of EMS data and demonstrating its unique and meaningful value not just to the EMS profession, but to the broader public health community as well. Nick Mercuri serves as the Bureau Chief of EMS for the state of New Hampshire. He spent his career in EMS, starting as an EMT in Boston before becoming a paramedic and later a lieutenant at the Guilford Fire Rescue Department in New Hampshire. He's led New Hampshire's State EMS Bureau since 2013. Dr. Jeff Elder is the Director and Medical Director for New Orleans EMS. He serves as the Medical Director of the New Orleans Fire Department and as the Chief Medical Officer for the New Orleans Office of Homeland Security and Emergency Preparedness. He is also a clinical assistant professor in the section of emergency medicine at the University Medical Center in New Orleans. And Dr. Joe Cantor is the medical director of the New Orleans Health Department. as well as the Healthcare for the Homeless Clinic in New Orleans. Joe is a practicing emergency physician at the University Medical Center. He's a clinical assistant professor of medicine at the LSU Health Sciences Center and a clinical advisor to the Catholic Charities Guardian Program. And again, my name is Noah Smith. I serve as your moderator for this EMS-focused webinar series. And so with that, it's really my pleasure to introduce our first speaker, Jeremy Kinsman from our office at NEMSAC, who is going to provide a national overview of the opioid overdose epidemic. Jeremy.
Well, thanks so much for that nice introduction, Noah. I really hope that those participating today on the webinar will find the information we're presenting meaningful and informative as we continue to work together across sectors and at all levels to combat this very serious public health problem. So as Noah mentioned, my name is Jeremy Kinsman. I'm a public health fellow in the NHTSA Office of EMS. My fellowship really centers on the integration of public health and emergency medical services systems. And so over the past year, I've been focused on researching and monitoring the opioid overdose epidemic for the Office of EMS, and also looking across the country to see how EMS, public health, and public safety are working together to, one, kind of improve pre-hospital patient care for overdose patients, but also how are these sectors working together to prevent overdoses and facilitate referral to addiction treatment. Next slide, or I guess this is a good one. This data from the CDC, which shows us overdose deaths for all drug types, not just opioids. We can see that in the US in 2014, there were 42,055 drug overdose deaths. So that corresponds to roughly 3,500 deaths per month, 115 every day, and 5 per hour. So by the end of this presentation, 5 drug overdose deaths will occur in this country. I'm sure these figures are not surprising to folks on today's webinar, but I think they can help reintroduce the seriousness of this problem. I'd also like to point out that for 2014, drug overdose deaths, they were the leading cause of injury-related mortality. So it's more than motor vehicle crashes, more than gun violence, and more than suicide. This slide here shows a similar structure, shows us that drug overdose deaths where opioids were involved. And we can see that among the 42,000 drug overdose deaths in 2014 that we saw on the last slide, roughly 28,000 or 68% of those deaths involved opioids. So we can see that this corresponds to roughly 2,000 per month, 78 per day, and 3 per hour. So among those 5 Americans that will die this hour from a drug overdose, 3 will involve opioids. Those are 3 Americans with families, friends, ties to our communities, and that's why today's conversation is so important. Next slide, please. So here we can see the rise in drug overdose deaths and those that specifically involved opioids in the US since 1999. And the top yellow line shows the rise in drug overdose deaths. The bottom blue line shows us the rise in drug overdose deaths that involved opioids. So in 1999, there were roughly 17,000 drug overdose deaths, and 8,000 of those involved opioids. As we move from 1999 to 2014, we saw a 146% increase in the rate of drug overdose deaths and a 210% increase in the rate of opioid overdose deaths. So here we can see the rise in opioid overdose deaths from 1999 and the types of opioids that were involved. So the graph suggests that the rise in opioid overdose deaths were largely due to opioid analgesics, and that includes prescription opioids, synthetic opioids, including those that are illicitly manufactured, and medication-assisted treatment drugs such as methadone. Now, when we look at the trend in overdose deaths that involve heroin, we can see that from 1999 until 2010, there wasn't a large increase. During that time period, the annual deaths from heroin stayed under 5,000 per year. But then we can see from 2010 until 2014, we see this really alarming increase in the number of overdose deaths involving heroin. So there's been some discussion that perhaps this increase in heroin deaths is the unfortunate result of kind of these efforts aimed at reducing inappropriate prescribing, implementing drug monitoring programs, and eliminating pill mills. But certainly these efforts have decreased the availability of prescription drugs, and there's some thought that this has driven non-medical users of opioid prescriptions towards heroin. However, a recent literature review authored by Wilson and Compton and colleagues, which was published in the New England Journal of Medicine in January of this year, concludes, and this is a direct quote from the article, that heroin market forces, including increased accessibility, reduced price, and the high purity of heroin, appear to be the major drivers of the recent increases in the rates of heroin use, and not the great public health efforts that are taking place to reduce access to prescription drugs. Next slide, please. Okay, so for my last introductory slide, I'd like to show an animation map that illustrates the rise in drug overdose mortality rates from 1999 to 2014 by state. So these rates show the number of drug overdose deaths for every 100,000 persons. On the bottom left of the map, you can see a legend there that shows the lightest color corresponds with less than 10 deaths for every 100,000 persons. And as the colors increase in darkness, the drug overdose mortality rate also increases. So the dark red color that you see, that indicates that there were more than 24 deaths for every 100,000 persons. And we can see that in 1999, the large majority of states had rates of less than 10 drug overdose deaths per 100,000 persons. So Kristen, if you wouldn't mind pushing play, you can see during the first few years of the 2000s, we see an increase in the Northeast, parts of Appalachia, and the Southwest. We then see increases across the Midwest, the Atlantic South, the Northwest, and the South Central states. We see rates steadily increasing across the country. And then finally, we see several states reach a rate of more than 24 drug overdose deaths per 100,000 persons per year. And that includes New Mexico, West Virginia, and New Hampshire. So hopefully these figures and graphs have provided us with some context of the problem we're facing. And with that, I'll turn things back over to Noah.
Thank you so much, Jeremy. We really appreciate the insight into the opioid crisis over the last decade. And with that baseline of information, it's my pleasure to introduce Nick Mercuri, who is the Chief of the Bureau of EMS in New Hampshire, to talk about what New Hampshire is doing and their statewide efforts to combat this crisis. Nick.
Oh, thank you very much, Noah, and thank you, Jeremy. And welcome, everyone. Thank you for your time today. And my name is Nick Mercuri, and I'm the Bureau Chief for Emergency Medical Services for the Department of Safety in New Hampshire. And we've just heard about the federal level, so we're going to come down a little bit and focus on more of the state level and what specifically New Hampshire has been doing to combat some of these, significantly rising rates. So in approximately 2013, we started getting some phone calls from our larger services that were looking at their data, and more anecdotally at that point, but they were noticing an increase in responses to overdose incidents and wanted to collaborate with us. As the State Bureau of EMS, we actually house our electronic medical record, and we've actually had one since 2005. So we were able to go back and start looking at some data after we kind of defined what a case was, which certainly itself was a challenge, where Narcan was actually being given because it was not just overdose cases. So after we looked at drug overdoses, respiratory arrests, and some other provider impressions, we really found some alarming information. And some of that information, as you can see on the screen, is from our look back from 2012 to 13, we saw a 15% increase. But 13 to 14, we saw a 45% increase, and that has continued, unfortunately, since that period of time. In response to that, because we have statewide protocols that come from our medical control board, we started having conversations about what do we do as providers at this particular point. So in March and May of 2014, the physicians that issue statewide protocols decided to push Narcan further down in our EMS provider chain. So instead of just the two top EMS providers, the advanced and the paramedics, they actually pushed naloxone down to the EMR and the EMT level. And what that did with us is that basically doubled the amount of providers we were able to allow to administer Narcan. New Hampshire itself is a small state. We've got 1.3 million folks, so not a whole lot. I'm sure there are some counties out there, probably larger than our state. But these 5,200 providers were really able to get more out into our rural areas. So that was really a positive thing for us, even though it's outside of the national scope. That was something that our Med Control Board really figured needed to happen to get to some of these other areas. Next slide, please. So as we pushed that down, we did create some training which the providers were able to take. But in the fall of 2014, the governor put together a task force, and that came up with a couple of law changes for us. And one of them was expanding the prescriptions, or the ability to write prescriptions within our state. But it also removed some of the restrictions on possession and administration of Narcan, and virtually made it an over-the-counter or as close to that kind of a medication as possible. Some of the EMS recommendations that came out of this task force included further expansion of Narcan, and in a long discussion of, can we get it to all first responders? So out of that discussion came an emergency rule change from our commissioner that allowed and actually created a law enforcement level of licensure for Narcan. Now, what we wanted to do around this is, because they're first responders and because of our rural nature of our state, we have many locations where law enforcement may get there before our volunteer fire and EMS do. So we're really trying to get that naloxone out to some of those levels. We did create some requirements for that licensure. Healthcare provider CPR, basic first aid, and a naloxone class that was also a classroom and a didactic practical portion of that. And at this point in time, we've got actually 89 law enforcement officers that are licensed to give Narcan in the state, and as far as we know, none have. But that was our way of fitting them into our system to, once again, kind of further put out the availability of naloxone, in addition to, at any opportunity we get, to really try to push out the importance of CPR to family and friends, because that really is going to make a huge difference while waiting for some of the rural services. Part of the conversation that also went along with the law enforcement is it's not going to work in every community. We've got larger communities. I'm going to talk a little bit about Manchester Fire in a couple of minutes and some of their unique ways of dealing with this. But in the larger communities like Manchester, our largest city, law enforcement naloxone wouldn't work because it is very rare, if ever, fire and EMS is going to have law enforcement get there before them. So it's not going to work everywhere, but it was another tool in the toolbox for some communities to use. Next slide, please. So one of the other things that came out of that task force was trying to do some more collaboration with DHHS, our Department of Health and Human Services, to expand Narcan. And what they ended up doing is we were part of a group with the Department of Health and Human Services to figure out how to get Narcan into some of our community health centers, whether they were federally qualified centers or not. And part of the discussion there and part of the funding from HHS allowed the purchase of approximately 5,000 Narcan kits. And to date, we've actually distributed over 4,800 kits to our community health centers, who in turn could actually get it in the hands of some of the people that they were seeing for substance abuse issues. So part of the, other part of that also initiative engaged the Department of Safety and the Bureau into doing some education. So we did two things around that. Is one, we were able to actually take some of grant funding and actually offer some law enforcement training, which is ongoing at this particular point in time, and develop a train-the-trainer program. As you can imagine, there are some community health centers that have more medical resources than others. So with the law change that allowed not just medical folks to possess or deliver Narcan, we were able to do some train-the-trainers and engage our Medical Reserve Corps and our Metropolitan Medical Response group within the state to basically make them instructors and make them comfortable with teaching more of the local folks, and then basically a train-the-trainer model around getting more Narcan training out there. Additionally, EMS units, if they felt comfortable or if the community health center had a strong relationship, it doesn't mean that our EMS providers couldn't do it. It's just trying to add more folks to that list that the community health centers could draw from. At this point in time, we've educated 64 train-the-trainers and 89 officers within that program. Next slide, if we could. One of the unique things that we were able to do in New Hampshire that didn't have anything to do with the opioid crisis was establish mobile integrated health care, or basically EMS in the home, and doing more home care type calls, which we collaborated with the Home Care Association. But out of that, Manchester Fire Department actually came up with a very unique opportunity. They were seeing a huge increase in the amount of overdose calls they were seeing. Some of the calls that we got initially that I spoke about came from American Medical Response, which is Manchester's EMS contracted service. So in that kind of collaboration, AMR and Manchester Fire Department and their EMS folks down there actually came up with a program that fit into our mobile integrated healthcare umbrella. In our state, we have some prerequisite protocols. So to use mobile integrated healthcare, you needed some training above and beyond and some medical oversight above and beyond our normal set of protocols, and this is one of them. So what they did is they uniquely put together a program with some, like I mentioned, with American Medical Response. The Catholic Medical Center is their medical resource hospital, and a local substance abuse program, and really said, how can we collaborate to not continually take people to the emergency department that didn't necessarily need to go? Now, certainly people need a medical evaluation, but everyone may not necessarily need the emergency department services. So one of the things that they did is they came up with a program, and it allows redirection of stable patients. And I want to emphasize that, is they do a medical evaluation that is signed off by their medical control physician, and they're able to offer different transport to these patients. So there are some patients that go to the emergency department, and there are some patients that are able to put it directly into substance abuse programs. I wish the Safe Station logo and statistics came out a little bit clearer for you, but they've done over 200, almost 300 patient interactions. They have 10 firehouses within the state, and they've been able to safely divert several of these folks to more appropriate locations. So that has worked out very, very well, and like I said, there's a very strong connection with medical oversight, and those cases are reviewed by the medical director. But that is in its very early stages. They've only been operating, I think, since April of this year. So they've had some good success, but certainly we've got to look at more of the data as it comes down the pike. One of the other programs within the state is more of a community care, where they've done some hands-only CPR and some Narcan distribution, and this is American Ambulance. And what they've actually done is their mobile integrated healthcare program is they've identified folks they've responded to or gotten a referral from. They'll actually go into the home and offer hands-only CPR to patients and their families, and actually distribute one of the state Narcan kits that I spoke about earlier, and do some education with them on how do you use it, signs of using or signs of needing the Narcan. And also, if there's substance abuse programs within the area of American, they'll give some information that people can ponder over. So those are two programs in the state at this particular point. One of the big pieces for us is collaboration with data. This situation prompted us to further collaborate. If we can go to the next slide, further collaborate on some of the data. And like I mentioned, that we took a look back at some of the information that we were getting, but we also developed a couple of different products. One of them you can see on the right is a monthly reporting for Narcan. That's something that we distribute, or we actually develop out of our electronic database, or electronic medical record, about once a month, and we really try to take a look at what's happening in trends within the state, not only a town level, but also on a per call level, and I'll get into that a little bit. One of the other things that we have within the state in collaborations with Health and Human Services is we have an information and analysis center. It's under the Department of Safety, and this is a fusion center is another word for it around the country. So they actually are taking our information, Health and Human Services, ER information, information from the medical examiner, and actually putting it into a report. So we can all stay on top of, and it's one central kind of area where we can take a look at some of that information and really take a snapshot of how we're doing statewide. Next slide. So in trying to kind of pull all these pieces together, you'll see a couple of charts come up, and these are just a couple of examples of what we've been able to do in the state. The top chart is us taking a look from 2012 until now on the Narcan administrations to see where we're going, and obviously the 2015 to 16 isn't a representative because it's only part of the year. The map on the right is really taking that information and trying to map it to our state to see where some of the hot spots are, and obviously keeping in mind that we've got to protect some of the information because it still is medical information. So we've got to go by HIPAA, and we've got to make sure that things are protected and cleaned enough that we're not giving out too much information. This actual map is on a 12-month rolling basis to make sure that we're protecting any identities or any. We've got some small communities within the state, so one case in a small community may be very identifiable, so we're very conscious of that. And then the last chart down to the right is really trying to take a look at the Narcan doses per call to see if we're seeing any kind of an increase. So these are just a couple of things that we're able to do with some of our data. Still like to be able to do much more with it, but this is a snapshot of what we've been able to do at this particular moment. So with that, thank you very much for listening, and thank you anyone on the call for what you do. We're in a very interesting situation, and it's only through pulling together and really taking a look at this information that we're going to be able to make any kind of headway. So thank you.
Thank you so much, Nick. Really, thank you for sharing your perspective and your experience in New Hampshire with us. I learned a lot in your presentation, and I have a lot of questions, as do many of the folks who are listening in. A lot of great questions are coming in. I appreciate those. We want them to keep coming, and we will get to as many as we can in the Q&A at the end of our session. I'll just say to you, Nick, and to the folks in New Hampshire that it was really nice to hear that the decision that you all made to expand your scope of practice in New Hampshire to allow for EMTs and EMRs to administer naloxone, that doubled the number of providers who can offer that drug in your state. And clearly you had and have a lot of support and a lot of attention as well from the top in your state. It's just very good to see that EMS is a key player in the statewide efforts in New Hampshire. So thank you so much for offering that experience to us. And now, just as you said, Nick, we're sort of going from a federal perspective to a state perspective, and now we get to hear an incredible local perspective. And it's really a pleasure to introduce Dr. Jeff Elder and Dr. Joe Cantor. Dr. Elder is the Director and Medical Director for New Orleans EMS, and Dr. Cantor is the Medical Director for the New Orleans Health Department. So Drs. Elder and Cantor, please.
All right, well, thank you and good afternoon. Just on behalf of the city, I'd like to thank Jeremy, Noah, and NHTSA for allowing the city of New Orleans to participate in this. And so it's just really a great opportunity. So if we could go on to the next slide. So in August of 2014, guidance was released by the state of Louisiana that allowed for training and implementation of naloxone use by first responders. Previously, this was limited to EMS providers above the level of EMT in Louisiana, and this really allowed us to expand the providers that could administer naloxone. For a little bit of background in our system, New Orleans EMS is a third service 911 provider for the city of New Orleans. All of our ambulances are staffed at the ALS level with typically one paramedic and one EMT partner. We've been using naloxone intranasally, intravenously, intramuscularly for years. So functionally, this legislation didn't change the capabilities of our EMS units. However, as part of our EMS system in New Orleans, the New Orleans Fire Department is dispatched at the EMR or EMT level to our most serious Code 3 calls for service. So as the medical director for both fire and EMS in the city, I authorize naloxone training and implementation for the EMR and EMTs in our system. The State of Louisiana Bureau of EMS Training modules were used to train EMRs and EMTs in intranasal administration of naloxone throughout our entire EMS system in the city. Later, in January of 2016, I was working a clinical shift in the ED when, by word of mouth, paramedics noted an increase over the past few days of opiate overdoses. This information triggered us to look at where we were using naloxone and how often it was being administered. We could go on to the next slide. By using our EPCR data, and we use image trend in our system, we quickly noticed that we had gone from an average of about 2 uses per day to a max of up to 10 administrations in a day, with an average of 5 naloxone administrations per day. We were able to heat map this and quickly share some of this data with Dr. Joe Cantor at the New Orleans Health Department to take really a deeper dive into what this looked like in our community. And so for the rest, I will transition over to Dr. Cantor.
Thanks, Dr. Elder. So my name is Joe Cantor, and I serve as the medical director for the City of New Orleans Health Department. And I hope to be able to give a little bit more background and a flavor for how this played out on a local level, and some examples of ways that the public health apparatus of the city can partner, in this case, partner very successfully with the EMS services to address this. As you know, the trends that Jeremy mentioned in the beginning that are going on nationally with increased overdoses and increased heroin use certainly was present in New Orleans as well. And as Dr. Elder mentioned, earlier in the year, around end of 2015 and beginning of 2016, we started hearing anecdotal reports from local emergency departments that they were seeing increased overdose cases, suspected opiate overdose cases. These were just anecdotal, and they were pretty similar to all types of anecdotal stories we hear. We turned around after we heard those and sat with EMS and quickly realized that EMS was the only entity in the city that really had a bird's eye view. Each emergency department only saw, you know, a sliver of what was going on, all told, and the demographics that would frequent different emergency departments were different, so that each ER sliver was quite different. It was really only EMS that knows what's going on throughout the whole city, because they're transporting patients to all the area hospitals. So they verified based on their Narcan usage numbers that there was an increase, about 3 to 4 times or so, in the amount of naloxone they were giving out. So in the health department, this allowed us to really verify what before that was just anecdotes, that we really do have a problem and we need to address it. We found out later on that a lot of these overdoses were related to fentanyl, either being mixed with the heroin or even being administered all by itself, as has been reported in other cities as well. That data came from the coroner, but the coroner's tox reports and final autopsy report doesn't come back for somewhere between 1 and 2 months after a death, which doesn't give enough immediacy to really recognize the problem. It's really only EMS's data showing increased transports and increased naloxone usage that was let us recognize and verify that we had something acute going on. So we sat down with EMS and we crafted a response. The first thing we did was we issued a standing order for naloxone. We made it so that any bystander, any regular resident of New Orleans could go to the pharmacy and obtain naloxone on a standing order under my name. It wasn't strictly over the counter because they had to go up to the pharmacist, and by doing that, the pharmacist had a few minutes to give them brief training in opiate overdose and how to administer the medication. But there was no separate need for a prescription. We modeled that off a very successful program in Baltimore that did very similar and had great success with that. The second thing we did was we sat down with the local emergency departments and really increased our ability to track and monitor instances of opiate overdose. We got some systems in place where they feed their numbers on a monthly basis to the health department so that we can keep track, and we take those numbers and compare them to EMS's to figure out what's going on. Then the third thing we did was we initiated a pretty broad educational campaign. We wanted to cover the signs of an opiate overdose. We wanted to cover proper administration of naloxone and how to care for the patient beyond that, namely that you still need to call 911 and engage EMS even after giving naloxone. And then we wanted to get across all the areas, substance abuse resources, rehab, detox, what was out there in the community to help patients through this. Next slide, Kristen, if you don't mind. So with EMS and with the local trauma center, we hosted a large press conference. We had media coverage, and we launched this initiative. We leaned very heavily in that on EMS for their expertise in this area. EMTs and paramedics are highly respected in New Orleans. They're a trusted authority, and having them up there with us gave immediate legitimacy to our response. It gave immediate legitimacy to the notion that naloxone is a safe medicine for bystanders, because EMS could lean on many, many years of successful administration on their part to speak to its safety. And seeing a trusted authority figure up there on the podium with the health department, I think really gave, it framed it very well for the community. It gave importance and immediacy to the issue. One point I wanted to make here is the importance we found of working with the state legislature on issues pertaining to naloxone. There's a huge amount of variance across states in terms of legality and access to naloxone. And a few years ago in Louisiana, we were quite restrictive in that regard. We worked pretty closely with a few key allies in the state legislature over the past couple of years to make it a more compassionate and favorable environment in terms of naloxone in Louisiana. And then the most recent example of that is after we had launched this initiative, we started hearing from outreach groups that were involved in community response or harm reduction, or really were on the street counseling folks, that they felt handicapped, that they couldn't give out naloxone themselves, that they had to send a client or a client's family to the pharmacy first, and they felt that in and of itself created a barrier. So we went back to the state legislature and we conveyed those concerns. And in the summer session a couple months ago, we got the law amended to make it so under a very similar standing order, outreach groups themselves could possess and distribute naloxone and train clients in how to use it without having to send someone to the pharmacy. And that increased the number of units we were able to get out on the streets. Go to the next slide, Kristen. Thanks. So to summarize real briefly, what we realized in this endeavor was EMS really was the one entity that had a bird's eye view of what was going on in the city and could piece together the dots and tie the stories together that each of the emergency departments were seeing on their own. And then EMS became highly valuable in our efforts to educate the community. They were a trusted and respected authority figure, and when EMS gets up there and says naloxone is safe to use, and we use it, and we think that lay people can use it as well, that carries a lot of weight, and we're very appreciative for their partnership in that. A couple caveats I wanted to mention pertain to how this data is compiled. No data is perfectly clean, and this certainly is true as well. So when we try to get data from the emergency departments, there's really two sources that we can get. We can either get a triage complaint or we can get a discharge diagnosis, an ICD-10 diagnosis. Neither of those was perfect. So in triage complaints, it's very difficult for the initial complaint to differentiate between what they overdosed on, whether they're with alcohol or opiates, or oftentimes a triage complaint will say intoxication, and that does little to help you differentiate what's really going on. Likewise, when you pull off of a discharge diagnosis or an ICD-10, sometimes you'll get heroin overdose or opiate overdose, but oftentimes you'll get drug overdose or intoxication or respiratory depression or altered mental status. And those as well make it difficult to really piece out what's going on. So I think we have a little work to do to make our data collection a little bit cleaner on the hospital end. And Dr. Elder, do you want to mention the EMS data?
Sure, just briefly. You know, the data is complicated. It's CAD data from EMS dispatch versus electronic patient care report information, and it doesn't always look the same. So for us, we looked at our first watch triggers and what we captured at the dispatch end versus our EPCR naloxone administration. And so we're still actually working with that to try to figure out what's the best way to report it. There are some ways now that people are looking at actually combining both the front end and the back end. But for now, we've kind of taken the stance that really our naloxone administration is probably the best thing that we can follow, and we're looking at ways to better fine-tune our data on the front end, working with some of our triggers to get just some better overarching data.
So I think with that, I'd like to turn it back over to Noah to give us a little bit more information of the federal response that's happening right now.
Thank you, Joe, and thank you, Jeff, very much for that incredible perspective from New Orleans. It's really great to see a health department and an EMS agency working hand in glove like this. And when we learned a little bit about what you all were doing in New Orleans, we knew that we wanted to feature you on this webinar. And so thank you very much for sharing that with the community today. We have a lot of really good questions coming in, particularly about some of the technical data sharing pieces that both of you were talking about. Those are certainly of interest to me as well. And so we're going to try to get to those by the end of the hour. Also, folks listening on the phone, just recognize that what we try to do with the questions that we don't have time to answer on the phone here today is to compile them into a Word document and to provide written answers and post those on ems.gov as well. So you can look forward to answers to your questions at a later time. But in the interest of time, I'm going to hand it over back to my colleague, Jeremy Kinsman, who's going to provide a little wrap-up and some information on what the federal government is doing to address the opioid overdose epidemic. Jeremy.
Thanks, Noah. For the final presentation for today, I'd like to discuss some of the current EMS-related federal efforts that are aimed at reducing the burden of overdose epidemic. And in the interest of time, I may just go through some of these slides rather quickly so that we have enough time for questions. Next slide, please. So the Office of EMS here at NHTSA, the mission really centers on improving EMS systems across the country. And one of the ways we do that is through the development of evidence-based guidelines, or EBGs. This is a multi-step process. First, there's some recognition, that there's a unanswered question about pre-hospital care for a specific medical or trauma emergency. And in the case of opioid overdose patient care, the EMS community across the country and the larger healthcare community, we realized that there were some questions about pre-hospital naloxone administration and patient disposition for opioid overdose and abuse patients. So some of those questions included: what is the most effective and safest route of naloxone administration? Is there a maximum allowable dose or threshold? And what is appropriate in terms of patient disposition? So what we did is we kind of come up with those questions, and then through a systematic review process, we look through the scientific evidence, we look through the literature, and we see if there's any evidence that supports the answers to those questions. So for instance, are there studies that indicate intranasal administration of naloxone is more, less, or equally effective compared to intramuscular administration? Once we answer all those questions through the systematic review, the results are used to develop the evidence-based guideline. And that ultimately will help inform our state and local protocols, our EMS textbooks, curriculums, and continuing education trainings. So in April of this year, the Center for Medicare and Medicaid Services, the National Institute on Drug Abuse, the CDC, us here at NHTSA, and SAMHSA, we work together to fund a systematic review of the evidence for the pre-hospital management of the opioid overdose patient. And that's managed by the Agency for Healthcare Research and Quality. That was awarded to Oregon Health Sciences University. And over the next year, they will be doing the systematic review, and then from there, we will develop the evidence-based guideline. Next slide. So after the EBG is published, the work doesn't really end for our office. We here at the Office of EMS, we're always thinking about new, effective, innovative ways to distribute the most recent guidelines. So one of the ways that we're exploring and to do that is through electronic learning management systems, or ELMS. So we've been working here at NHTSA with the National Center for Disaster Medicine and Public Health and the National Association of State EMS Officials to try and see if ELMS has potential for EMS providers across the country. I think we all know that often there's public health emergencies like the opioid crisis. There's disasters where we need to be able to very quickly and educate providers all across the country. ELMS is potentially one way that we might be able to do that. Next slide. I'd just like to quickly mention the Comprehensive Addiction and Recovery Act. This was passed and signed into law on July 22nd of this year. It does include authorization, but there's currently no funding. So there are several programs there that would be, I think, of interest to our state and local EMS partners. And as things develop, as we learn about funding opportunities, we'll be sure and share that information with our state and local partners. Next slide. So there's been interest by the public health community and our national and state partners regarding naloxone access in the pre-hospital setting. And so in support of our partners, our office has been busy at reviewing state law related to EMS provider levels that are authorized to administer naloxone and the modes of administration that are authorized. So over the past 2 to 3 years, we've seen most states change their state law to allow EMTs to administer naloxone. And as of May of this year, there were only 9 states that had not yet expanded naloxone administration to the EMT level. At that time, most of those 9 states, however, were in the process of making the change. Next slide, please. So this is a similar map. It just shows the emergency medical responder level and the modes of administration that are authorized for EMRs by state. As of May of this year, there were 18 states and the District of Columbia that do define the EMR level in their state law, but did not allow them to administer naloxone. So from a public health perspective, it's great to see that most states have expanded naloxone to the EMT level, but I think we have some work to do in expanding authorization to the EMR level. Next slide. So I think there's great need among national leaders and organizations to understand the scope and trend of the opioid overdose epidemic. As I demonstrated earlier on my introductory portion of the presentation, we can see that the CDC is really leading the way with providing publicly accessible mortality data that is informative and valuable in measuring the state of the epidemic. I think EMS data that is aggregated at the national level, what we call the National EMS Database, is also a great tool for measuring the state of the epidemic. And we can see here some data from the National EMS Database. So we know from that database that EMS personnel administered naloxone roughly 150,000 times to 126,000 patients in 2014. Next slide. So here we can see a graph. This shows the rise in naloxone administrations by EMS practitioners in the US from 2012 to 2015 by month. Again, this is data from the National EMS Database. And we can see that there is a upward trend from January of 2012 up until January of, of December of 2015. Next slide. So here we're seeing the same information as the previous graph, but we're also seeing a comparison. We've added a trend here from drug overdose mortality data from the CDC, and we can see that the trends are similar. I think this is really important for 2 reasons. One, it shows that EMS is responding to the epidemic by administering naloxone in the pre-hospital setting, and 2, it shows that EMS data has some value in measuring the state of the opioid overdose epidemic at a national level. Next slide. This is a similar graph, but instead of drug overdose data, now we're just looking at opioid overdose mortality data and the naloxone administrations by EMS practitioners. And we see, again, a similar trend. Next slide. So for my last two slides, I'd like to discuss and advocate for a collaborative EMS systems approach in the response to the opioid overdose epidemic. And I think while naloxone is certainly a vital medication that should be available to all EMS providers, I think that EMS has a much larger role to play as well. And I think as we've demonstrated today, EMS data, the development of evidence-based guidelines, new education and training methods, innovative patient referral programs, and legislative advocacy for patients, those are all part of a systematic and collaborative EMS approach. And I think those are the types of efforts that are going to save the lives of the 5 Americans who will die in the next hour from a drug overdose. Next slide, please. So in closing, we often see this graphic to demonstrate that EMS has multiple roles and responsibilities. That is, EMS professionals, we provide health care, public health, and public safety to our communities. I think we can see this graphic in another way, that EMS has the opportunity to bridge gaps in public health, public safety, and healthcare. So we are right now, I think, bridging those gaps in 2 primary ways. One, EMS data at local, state, and national levels can help us bridge gaps, I think, that exist in tracking the state of the opioid overdose epidemic. And 2, as EMS providers, we're on the ground with these patients suffering from opioid addiction every day. So we act as a physical bridge, I think, ensuring that our patients are connected to immediate life-saving health care, but also rehabilitation services. Thank you very much. And with that, I'll hand it back over to Noah.
Fantastic, Jeremy. Thank you so much. I could not have summed up what I think are the opportunities that EMS has to impact this crisis any better than you just did on the last 2 slides. So thank you for that. And thank you to all of our presenters. Before we open it up to questions, I just need to put a quick plug in to something called the National EMS Advisory Council, or NEMSAC. And as Jeremy showed us over the last few slides, there are several states that have not expanded their scopes of practice to allow EMTs and EMRs to administer naloxone in the field. And so you may recall that in 2007, published what we call the EMS scope of practice model that many states have adopted as a floor for their scopes in their states. And in response to the growing epidemic, we asked the National EMS Advisory Council the question that you see on your screen. Should we revise that document to add the administration of narcotic antagonists to the EMR and the EMT scope of practice? And if so, what sort of supporting resources and materials would states need to implement that change? And a committee of the NEMSAC has developed a draft recommendation that's open for comment and review right now. You can head to ems.gov and click on NEMSAC. When you're there, you can click on the meetings page and you can find the agenda and materials for their upcoming meeting, which is just in 2 weeks here in Washington, D.C. You can download a draft of their recommendation to us in response to that question. You can comment on it and they will read your comments. And you can comment by sending an email to nemsac@dot.gov. We encourage you to look at the draft at the link on that slide there and email your comments again to us before the meeting on September 7th and 8th. So we know that we did not leave as much time as we wanted for questions today, but I assure you that we are compiling all of your questions and we'll ask our very generous presenters to provide written responses to those questions, both directly back to you and posted on ems.gov, along with an archived copy of this webinar. I will just ask one question that we received from several folks throughout the presentation, because a lot of this had to do not as much with the provision of medical care, but what we can do with the information and the data that we're collecting every single day at a local level, at a state level, and indeed at a national level. One of the barriers that we hear a lot about is some of the restrictions that HIPAA, the Health Insurance Portability and Accountability Act, puts on the movement or sharing of that kind of protected health information. And so I'll just ask each of the presenters, maybe from the state and local level, beginning with Nick from New Hampshire, what your experience was in dealing with protected health information and how you overcame any barriers that may have been put in place in regards to HIPAA restrictions. So we'll start with Nick and then we'll ask the folks from New Orleans.
No, thank you very much with that question. I think it's a very, very interesting one, and we could go on for quite a while to try to discuss that one. How we overcame it is we ended up taking a look at our Department of Health and Human Services and some of the data that they had collected, and they had come out with some draft documentation on how to maintain the confidentiality of information while still being able to release enough information to be worthwhile. So we worked very closely with them on what some of the HIPAA requirements were, but also on how to clean the data. And one of the things that I had mentioned is our map is a 12-month rolling map for a reason, because when you take that into account with the 12 months of data, you have ranges of data. Those were some of the protections that we put into place so we could publish some of the information. Our monthly report goes into it a little bit better, is when there are numbers that are too small within our community, we aren't able to release some information, so we blind it, so to speak. But we worked very closely with Health and Human Services around that, because there was a webinar, I think, in the past week or two about HIPAA and data. And it was very, very interesting, and keep this very short, is that there's still a lot of misconception out there about how you can use information. And there's still a lot of people, even, I guess we're 20 years post-HIPAA, that still believe that absolutely nothing can be released. And we're learning more and more through case law and other such things. But we engaged partners who were dealing with like vital statistics on a very regular basis. That's how we overcame that, that challenge.
A lot of lessons to be learned there. Thank you, Nick. And from our partners in New Orleans, Jeff and Joe.
Hey, this is Jeff. Yeah, I think I couldn't agree more. You know, it's really just kind of educating people on how you can share the data and what you can share. For us, our data is really pretty well blinded. We're really just looking at numbers, numbers of administrations, numbers of overdoses. And we're not getting into some of the granular detail like blocks and street levels and things like that. Some of the heat mapping was over time and over kind of a larger area, and so we use that. And for us, most of the data sharing really is between EMS and the health department. And in New Orleans, EMS actually sits under the health department by city charter. And so it was just very easy for us to just go back and forth with some of the data to look at kind of what was happening in our community.
This is Joe. I'll second everything that Dr. Elder said. You know, when we ask for data, whether it's from EMS or from the hospitals, it's always an aggregate number of cases per week or per month. And if the number of cases in that time period is small enough to allow someone to really identify off of it, then we'll just pull that with, we'll stretch out the time period. So we never ask for anything more than just aggregate and stats. And I will add that, you know, that's analogous to how we do infectious disease reporting. So, you know, hospitals report cases of infectious disease to local and state health departments all the time. And we should really be thinking of substance abuse problems like any other disease. And I think doing the reporting in a similar manner argues towards that.
A fantastic analogy, Jeff, and thank you for that. I want to thank all of our panelists very much from New Orleans, from New Hampshire, and from our office at NHTSA for taking the time to share their perspective and their experience with us today. I think we learned a lot today. We learned a lot about how EMS is at the front lines of the opioid epidemic in this country, about how the information and the data that we're gathering every day on our patients is valuable not just to us and to them, but to the broader public health and law enforcement communities that are working to try to reverse this epidemic in our nation. I think we learned that we play a large role in reversing the epidemic and the crisis, not just in the administration of naloxone to someone who is experiencing a personal crisis, but indeed in terms of prevention and identifying the best opportunities and the best locations to provide services from a broader, more preventive perspective. And I think that's really where EMS does come in line and is part of not just healthcare and not just public safety and not just public health, but all three indeed. So with that, well, thank you very much for staying a few minutes past the hour. We'll thank our panelists and our participants again, and we'll wish you a very happy rest of the day. Thank you all.